So I want you to imagine a perfectly sterile, impenetrable vault.
Okay, I like where this is going.
Right. The walls are thick, the internal environment is just perfectly balanced, and it's completely sealed off from the chaotic, germ-filled world outside.
Which is, exactly what the human eye is.
Exactly. It's protected by this remarkably tight blood-ocular barrier. But the big question is, what happens when that vault is actually breached?
Yeah, when a pathogen literally gets inside, it's bad news.
It's terrifying. Because the tragedy is that the very immune response meant to save the vault ends up, destroying the delicate retinal tissue from the inside out. You can blind a patient in a matter of hours.
Hours. Time is tissue here.
Absolutely. So welcome to this deep dive. If you're joining us, you know that we are dedicated MCCQE reviewers, and we're here to help you, the Canadian medical student, feel fully prepared and incredibly comfortable with the exam review process. We'll be breaking down all major concepts covered on the exam.
And just to set the clinical stage right up front, the foundation of our discussion today is derived directly from highly reliable StatPearls articles. We're extracting the absolute highest yield pearls for your boards to make sure you really understand the underlying mechanisms, not just memorizing facts.
Right. Mechanisms are key. But before we unlock this vault, a quick but crucial clinical disclaimer. This deep dive is strictly for medical education. It is not medical advice. Any clinical decisions in the real world must involve a qualified healthcare provider.
Always.
So with that out of the way, today's high-yield topic from the head and neck, eye, and ENT section is an absolute ophthalmic emergency. We are talking about endophthalmitis.
It is a devastating condition. I mean, truly. Our mission today is to equip you with the exact definitions, the clinical presentations, the diagnostic workup, management steps, and of course, those classic exam traps.
Because the MCCQE loves their traps.
Oh, they do. And like we said, time is tissue, especially retinal tissue, which basically has minimal to no capacity to regenerate once it's gone.
Right, once it's gone, it's gone. So let's start with the breach itself. By definition, endophthalmitis is inflammation of the inner coats of the eye. So we're talking specifically the vitreous and aqueous fluids caused by the intraocular colonization of infectious agents.
Which triggers heavy exudation, yeah.
Right. But, the MCCQE isn't just going to ask for a textbook definition. They really want to test your clinical reasoning on exactly how the pathogen gained access.
Because the route of entry completely dictates the causative organism. You have to classify this into two main categories, right? Exogenous and endogenous.
So exogenous meaning the pathogen came from the outside environment.
Exactly. The vault door was physically forced open. This is usually post-operative, like after routine cataract extraction, or it's post-traumatic.
Got it. And then endogenous, on the other hand, is hematogenous spread.
Right. The vault door is still locked, but the invaders sneak in through the building's own internal ventilation system, essentially, the bloodstream.
That's a great way to picture it. And looking at the microbiological epidemiology, if you're a student and you just have to blindly guess a pathogen class on the exam for endophthalmitis, gram-positive bacteria is the safest bet, right?
Oh, for sure. It accounts for over 85% of all isolates.
Wow, 85%.
Yeah, and mechanically, it makes perfect sense for exogenous cases. Think about intraocular surgery. The surgical instruments are passing right by the eyelids, the lashes, the adnexa.
Which are just heavily colonized by normal gram-positive flora.
Exactly. Which leads us right into the most common organism associations. So if a patient presents with acute postoperative endophthalmitis, which is defined as occurring within 6 weeks of their surgery, the most common culprit is that normal adnexal flora. Specifically Staphylococcus epidermidis.
Which just gets pushed in during the procedure and multiplies in the nutrient-rich vitreous.
Precisely.
Okay, but let's push back on that timeline a bit to explore a classic exam trap. What if a patient had an uncomplicated cataract surgery, say 4 months ago?
Oh, okay.
They wouldn't present with acute staph epidermidis, right? They might present with chronic post-cataract endophthalmitis. I know Propionibacterium acnes is the classic organism here, but how does its pathophysiology lead to such a totally different clinical presentation?
So P. acnes is an anaerobic, very low virulence bacterium. During surgery, it actually gets sequestered inside the capsular bag.
Wait, the capsular bag?
Yeah, it's that thin avascular membrane that surgeons purposely leave behind to hold the new artificial lens. So because the bacteria is sequestered in there and it's super slow growing, the immune system has a really hard time clearing it.
So it's like it's hiding.
Basically, yeah. So instead of a massive acute purulent response, the body just tries to wall it off.
Which totally explains the specific physical exam findings you see on the boards. The immune system tries to wall off the infection, macrophages fuse into giant cells, and you get this granulomatous reaction.
Right. It's a slow, low-grade peniveitis.
You see, granulomatous keratoc precipitates on the cornea, and this is the real giveaway, a distinct white capsular plaque where the bacteria are actively hiding.
Yes, that white plaque is a massive clue. And sometimes that sequestered P. acnes infection remains totally subclinical, for a long time, until the patient undergoes a Y capsulotomy.
Oh, right, the laser procedure.
Exactly. Months or years later, the patient develops posterior capsule opacification scar tissue, basically. So the ophthalmologist uses a Weyerhaeuser laser to blast an opening in the capsule to clear their vision.
And that laser energy physically shatters the capsular bag, releasing the sequestered P. acnes straight into the vitreous cavity.
Yep, and within days, you suddenly have this delayed onset endophthalmitis flare-up.
That is such a wild mechanism. Okay, let's shift to the post-traumatic breach. Say a farmer gets struck in the eye with a branch, or a machinist has a high-velocity metal shard pierce the globe. We still worry about Staphylococcus, obviously.
We do, but the highly virulent organism you absolutely must suspect in trauma is Bacillus cereus.
Right, Bacillus cereus, which is ubiquitous in soil and organic matter.
And it is a terrifying intraocular pathogen. It secretes this barrage of exotoxins, hemolysins, and terotoxins that rapidly digest retinal and corneal tissue.
Just melts the eye, basically.
Pretty much. It can completely destroy the architectural integrity of the eye within 24 to 48 hours.
Wow. Okay, so that's the exogenous side. Now, for the endogenous cases, the quote-unquote inside jobs arriving via the bloodstream, these are typically secondary to fungemia, right?
Yeah, with Candida species being the most common worldwide, usually you see this in immunocompromised patients or folks with indwelling central lines.
But for bacterial endogenous cases, the patient's geography is actually a massive clue on the exam.
Huge clue. In Western populations, you're looking for staphylococcal species seeding from, say, endocarditis or IV drug use.
No, but in East Asian populations, it's different. The predominant endogenous pathogen is Klebsiella pneumonia.
Yes, and typically associated with a primary liver abscess.
That's such a specific association. Why Klebsiella?
Well, these specific strains have a hypervirulent phenotype. They often have this really thick K1 or K2 polysaccharide capsule that makes them highly resistant to phagocytosis by macrophages and neutrophils.
Which allows them to survive the whole journey through the bloodstream, cross the blood-ocular barrier, and just see the eye.
Exactly. So
Yeah.
we've got a solid grasp on how the vault is breached and by whom. Let's pivot to the emergency department.
Yes, let's walk into the ER. We need to know what this patient looks like when they actually arrive and how to systematically work them up.
Right.
So the classic acute postoperative presentation involves a sudden, severe drop in visual acuity. You do a slit lamp exam, and you see corneal edema, vitreous inflammation that totally obscures the view of the retina. They've lost their red reflex, and you see the absolute hallmark sign, a hypopyon.
Yeah, that hypopyon is classic. Pathophysiologically, it's a dense accumulation of neutrophils and fibrinous exudate that settles inferiorly in the anterior chamber just because of gravity.
Because the infectious agents trigger all these cytokines, which breaks down the blood-aqueous barrier.
Right, so massive amounts of white blood cells pour into the eye from the iris and ciliary body vasculature. It literally presents as this visible white fluid level resting right in front of the iris.
Okay, so if the anterior chamber is just filling up with pus and degranulating neutrophils, the resulting inflammatory pressure and tissue irritation has to be just excruciatingly painful.
You would think so, yeah.
So if a post-op patient comes in with a hypopan and dropping vision, but they tell us, my eye doesn't actually hurt that much, we can confidently push endophthalmitis lower down on our differential, right?
No. That is a critical tract on the MCCQE. You cannot rule it out based on a lack of pain.
Wow, really?
Yeah. The endophthalmitis vitrectomy study, widely known as the EVS, they demonstrated that up to 25% of patients with confirmed endophthalmitis present with no significant pain whatsoever.
25%, that's wild.
Yep. Worsening pain is a classic textbook symptom for sure, but its absence should never deter you from making the diagnosis if the vision is dropping and that hypopyon is present.
That is definitely a pearl to highlight. Decreasing vision is almost universal. Pain is not. So what about specific clinical findings that point to specific organisms in the ED? We talked about Bacillus cereus with trauma.
Right, and Bacillus cereus toxins are so destructive to the corneal stroma that they classically cause this rapidly progressive corneal ring abscess.
A ring abscess. Got it.
If the clinical vignette describes a patient with a post-traumatic eye injury developing a ring abscess, Bacillus is the answer, every time.
And alternatively, if the vignette describes gas bubbles visible in the anterior chamber, or maybe this bizarre green-brown colored hypopyon.
Oh, that's a Clostridium species. Clostridium is an anaerobic fermenter, so it is literally producing gas as a metabolic byproduct inside the confined space of the eye.
Good to know. Okay, so the physical exam workflow for these patients requires extreme precision, especially when measuring visual acuity. The EVS established really strict standards here because the initial vision dictates the surgical management later on.
Right, you can't be casual about it. When visual acuity drops below counting fingers, we don't just, wave a hand randomly in front of their face.
Right, so what's the standard?
The standardization is vital. You must test hand movements at exactly 60 centimeters.
60 centimeters.
Yes. And if they cannot see that, you test light perception at exactly 90 centimeters, using the maximum brightness of an indirect ophthalmoscope.
And they have to get it right how many times?
The patient has to correctly identify the stimulus 4 out of 5 times for that reading to be considered their actual baseline vision.
Okay, 4 out of 5 times. Once that baseline is established, we need intraocular fluid to culture the specific bug. So the options are an anterior chamber aqueous tap or a vitreous tap and biopsy.
And the vitreous yields far more accurate cultures, hands down, because the primary site of replication for most of these pathogens is deep within the vitreous gel, not just circulating up in the anterior aqueous humor.
Right, so a vitreous tap or a biopsy using a vitrectomy cutter is the gold standard for diagnosis. You need to obtain undiluted vitreous before starting any treatment.
Exactly. You have to give the microbiology lab the best possible chance of identifying the pathogen and its sensitivities.
Okay, let me throw a wrench into this. Let's consider a severe clinical progression. A patient arrives with the poor vision and the hypopyon, but they also have a severely proptotic, bulging eye.
Uh-oh.
Right, and when you ask them to look left or right, their ocular movements are completely restricted. The eye is essentially frozen in the orbit. I assume we aren't just dealing with inflammation of the inner coats anymore.
No, the infection has officially jumped the tracks at that point. You have progressed from endophthalmitis to panophthalmitis.
Endophthalmitis.
Right, endophthalmitis is confined by the sclera. Panophthalmitis means the aggressive inflammation has enzymatically degraded and breached the scleral wall. It's invading the extraocular muscles, the orbital fat, all the surrounding orbital tissues.
So the restrictive motility and proptosis are signs of massive orbital involvement.
Exactly. At that stage, the structural integrity of the entire globe is compromised. The risk of the infection spreading posteriorly to the cavernous sinus or requiring evisceration, where you literally surgically remove the contents of the eye to control the infection, is incredibly high.
Terrifying. So we've identified this ticking time bomb in the vitreous. But that blood-ocular barrier we discussed earlier, it's a two-way street, right? It keeps normal flora out, but it also heavily restricts systemic drugs from getting in.
That is the big challenge.
Right. So this brings up the management protocol. How do we actually deliver drugs effectively to stop the destruction?
Well, the absolute gold standard for exogenous endophthalmitis is immediate intravitreal injection of broad-spectrum antibiotics. You do not wait for the culture results to come back.
You empirically cover for both gram-positive and gram-negative organisms by injecting medication directly through the pars plana into the vitreous cavity.
Exactly. Because relying on massive intravenous doses of specific antibiotics simply will not work for exogenous cases.
Why not? Just doesn't cross the barrier.
Right. The tight junctions of the retinal pigmented epithelium and the retinal vascular endothelium prevent therapeutic concentrations of 5E antibiotics from reaching the vitreous in time to actually save the photoreceptors.
Got it. And the EVS definitively proved that, didn't they? That adding systemic IV antibiotics provides no added benefit to final visual outcomes in exogenous endophthalmitis.
That's right. No benefit for exogenous.
Okay, but that rule applies specifically to exogenous cases. For our endogenous cases, the inside job seeding from the bloodstream, the source of the infection is systemic, like a liver abscess or an infected heart valve.
And therefore, endogenous cases absolutely require aggressive systemic intravenous antibiotics in conjunction with the intravitreal injection.
Right, because if you only treat the eye in an endogenous case, The continuous hematogenous seeding will just reinfect the globe.
Or worse, the systemic infection will literally kill the patient.
Yeah, that would be worse. Let's look at the specific pharmacology for those intravitreal injections. Historically, I know the EVS protocol used a combination of vancomycin for broad gram-positive coverage and amikacin for gram-negative coverage.
Right, historically. But the standard of care for the gram-negative agent has shifted significantly.
Tell us why.
While amikacin is an aminoglycoside, and it carries a remarkably high risk of severe retinotoxicity, it can cause totally irreversible damage to the macula, leaving the patient with a permanent central scotoma.
Wow, a permanent blind spot.
Yeah. So due to this toxicity profile, the modern standard has replaced amikacin with ceftazidime. It's a third-generation cephalosporin, and it provides excellent gram-negative coverage with a much, much safer retinal profile.
Okay, and speaking of aminoglycoside toxicity, there's a very specific exam trap medical students need to memorize regarding gentamicin.
Oh, yes.
If an exam question mentions the use of intravitreal gentamicin, you need to monitor for macular infarction. Gentamicin is directly toxic to the delicate retinal capillaries, leading to profound capillary non-perfusion and ischemic infarction of the macula.
It's a devastating complication. You definitely have to watch out for that on the exam.
Okay, so moving from pharmacology to surgery, we have to address the most debated question in endophthalmitis management, the vitrectomy.
Ah, the great debate.
So a pars plana vitrectomy is a major surgical intervention, right? Trocars are inserted into the eye, and a microscopic cutter is used to literally chew up and aspirate the infected vitreous gel, physically removing the inflammatory debris, the toxins, and the bacterial load.
Right, and mechanically that makes total sense. If there's an abscess in the body, you drain it.
Right. So let's test this with a clinical scenario for the exam. You are in the ER. Your post-cataract patient's visual acuity is strictly measured at counting fingers at 60 centimeters.
Okay, counting fingers.
Your instinct might be to rush them straight to the operating room to suck out all that toxic vitreous. Based on EVS guidelines, do we rush them to surgery or do we just perform a tap and inject antibiotics right there in the procedure room?
Based on the EVS guidelines, you do not rush to surgery. You perform a tap and inject in the procedure room.
But why? Why does the EVS tell us to hold off on surgery when their vision is already that compromised? I mean, why wouldn't manually extracting the infection always yield a better result?
Because the surgery itself is highly traumatic to an eye that's already incredibly compromised. In an actively inflamed, infected eye, the retina is incredibly friable.
It's fragile.
Extremely. Going in with surgical instruments and manipulating the vitreous in that state, it's like trying to scrape paint off wet tissue paper.
Ouch.
Yeah, the mechanical traction is highly likely to cause an iatrogenic retinal tear or a full retinal detachment. So the EVS data showed that vitrectomy provided better final visual outcomes only for the most severe cases. Specifically, patients whose initial presenting vision was reduced to light perception or worse.
Okay, so if they can still see hand motions or count fingers, the risk of surgically detaching the retina outweighs the benefit of clearing the infection faster. For those patients, immediate vitrectomy offers no better visual outcome than a tap and inject.
Exactly, and the MCCQE relies on these established landmark guidelines. So unless a question specifically points toward newer alternative protocols, stick to the EVS criteria. Light perception or worse equals vitrectomy.
Got it. And another tool in our pharmacological arsenal is steroids, specifically intravitreal dexamethasone, to manage that intense inflammatory cascade.
Right, because the host's own cytokines and TNF-alpha often end up destroying the photoreceptors faster than the bacteria itself.
But there is a hard, unbreakable rule with steroids on the board exams. Never, ever use steroids if you suspect fungal endophthalmitis.
Never.
Steroid profoundly suppress the local cellular immune response. If you inject steroids into an eye full of candida, you're essentially throwing gasoline on a fire.
Oh, totally. The fungus will proliferate uncontrollably without the immune system there to keep it in check. It's a disaster.
Okay, so the outcomes of this disease can be pretty devastating, even with perfect management, which makes mastering prophylaxis a vital responsibility for any physician. We need to prevent the breach from occurring in the first place.
Absolutely. And in the operating room, before a cataract surgery, there are proven prophylactic measures. The most critical is 5% povidone iodine antisepsis of the conjunctival, cul-de-sac, and eyelids. It drastically reduces the normal fluoride load.
And you also must check the patency of the nasolacrimal duct. If a patient has a blocked tear duct or chronic dacryocystitis, it basically acts as this massive stagnant reservoir for bacteria.
Yeah, and the moment you make a corneal incision, that bacterial reservoir can just wash directly into your sterile surgical field. It's terrifying.
Wow. And furthermore, at the conclusion of cataract surgery, it's standard practice to use intracameral antibiotics, meaning antibiotics injected directly into the anterior chamber, such as cefuroxime or moxifloxacin.
Right. But, no good deed goes unpunished in medicine. There is a very unique, highly testable complication linked specifically to the prophylactic use of intracameral vancomycin.
Yes, this is a big one. It causes a condition known as HORV, or hemorrhagic occlusive retinal vasculitis.
Right. HORV is a delayed type 3 hypersensitivity reaction.
So it's forming immune complexes.
Exactly. The body mounts an immune response against the vancomycin, forming massive antigen-antibody immune complexes. And these complexes physically deposit within the walls of the retinal blood vessels, which activates the complement cascade.
Leading to profound fibrinoid necrosis, clogging the vessels, and just causing catastrophic retinal ischemia and widespread hemorrhage.
It's awful. So while vancomycin is excellent for intravitreal treatment, its intracameral use for prophylaxis carries this rare but terrifying risk of HORV.
All right, let's talk about prophylaxis. For a procedure you will see constantly in clinic, intravitreal injections. Millions of anti-VEGF injections are performed every year for conditions like macular degeneration.
Very cool.
I read a fascinating statistic that completely changed how I view this procedure. The most common bacterial contaminant that causes endophthalmitis after a clinic injection isn't from the patient's eyelashes.
Yep.
It is oral streptococci.
Yeah.
I mean, how on earth is mouth bacteria getting into a patient's eye during a sterile clinic injection?
It's completely aerosolized. When a physician or a patient speaks, microscopic droplets containing oral flora are continuously expelled into the air.
So if you're leaning over a patient, just chatting with them about their weekend while you prep their eye for an injection,
You are actively aerosolizing oral streptococci directly onto their conjunctiva just seconds before you push a needle through it.
that is just a staggering realization. Simply talking to a patient during the prep could introduce a pathogen that blinds them.
Which is exactly why strict protocols are now the standard of care. A no-talking policy during the injection prep, combined with the mandatory use of face masks by both the physician and the patient, significantly drops the rate of post-injection endophthalmitis.
It's a highly effective, purely behavioral prophylactic measure.
Yes. Do not talk over an open eye.
It's an unforgettable anchor for the exam. But even with our strict prophylaxis, our advanced vitrectomies, and our broad-spectrum antibiotics, we really have to be realistic about the prognosis when endophthalmitis does strike.
Yeah, the clinical realities are grim. The EVS data showed that in post-cataract endophthalmitis, even with prompt and appropriate treatment, only 53% of treated eyes achieved a final visual acuity of 20/40 or better.
Barely half the patients get decent driving vision back.
Right, and 15% ended up at 2200 or worse, meaning they were left legally blind in that eye despite our absolute best efforts.
And if the condition progresses to a severe corneal ulcer or panophthalmitis, the risk of requiring an enucleation or evisceration remains just a tragic reality.
Time truly is retinal tissue.
Okay, so let's briefly synthesize the absolute highest yield takeaways for your MCCQE preparation. First, master the pathogens based on the route of entry. Exogenous breaches bring in post-op staph epidermidis or trauma-induced bacillus cereus.
Endogenous breaches bring in bloodborne candida or hypervirulent East Asian Klebsiella.
Second, understand the EVS criteria for vitrectomy. The retina is too friable to risk surgery unless the initial vision is light perception or worse.
Third, recognize the classic presentation of a red eye, decreasing vision, and a hypopanman, but never, ever forget the trap that pain is absent in a quarter of cases.
And finally, remember the mechanism of HORV as a type 3 hypersensitivity from intracameral vanco, and the no-talking rule to prevent aerosolized oral strep contamination during injections.
If you internalize those mechanisms and those guidelines, you will be able to confidently navigate literally any endophthalmitis clinical vignette the boards present to you.
Awesome. But before we sign off today, we want to leave you with a final thought to mull over something that pushes beyond the current textbook guidelines and connects to the broader future of medicine.
Yeah, consider the pathophysiology of endogenous endophthalmitis, which relies entirely on pathogens breaching the ocular blood barrier from systemic circulation.
What?
We are currently facing a global rise in multi-drug-resistant systemic infections. I'm talking about strains of MRSA or highly resistant Klebsiella that just completely defy standard treatments.
It's definitely a growing problem.
So how might this shift the landscape of ophthalmic emergencies? If these superbugs begin to routinely breach the ocular vault, will our standard empiric intravitreal therapies, our vancomycin and ceftazidime, will they continue to hold up?
Or are we steadily approaching a new ophthalmic crisis where the vault is breached by invaders we simply have no weapons against?
Exactly.
It is a totally sobering prospect. The biological fortress might be strong, but the invaders are relentlessly evolving. Thank you for joining us on this deep dive. Keep studying hard for the MCCQE, trust your preparation, and we will see you next time.